Hello, everyone, and welcome to today's healthcare provider program, Unraveling the Strand, Navigating Genomic and Genetic Testing with Your Patients. We're glad you could join us today. My name is Stephanie Washburn, and I'm the Manager of Healthcare Provider Outreach at Living Beyond Breast Cancer, or LBBC. I'm pleased to serve as your moderator today. In case you're just getting to know us at LBBC, we're a national nonprofit organization that offers trusted information and a community of support to people affected by breast cancer. We selected today's topic because of its importance to people with breast cancer and healthcare providers alike. LBBC is a member of the Consistent Testing Terminology Working Group, which is composed of more than 40 patient advocacy organizations, professional societies, pharma, biotech, diagnostics companies, and testing laboratories. These members are committed to clarifying and promoting consistent use of common terms for biomarker and germline genetic testing, and working together to achieve better communication between patients and providers about testing needs. Through this work, LBBC has adopted these terms: tumor biomarker testing to discuss tests that identify characteristics, targetable findings, or other test results originating from malignant tissue or blood. This is often called genomic testing in breast cancer clinical settings, and genetic testing for an inherited mutation for tests to identify germline mutations, also known as variants in the genetics community. To learn more about these efforts to develop consistent testing terminology, please visit commoncancertestingterms.org. Today's speakers, Dr. Generosa Grana and Evelyn Robles-Rodriguez, will help us understand genomic testing, or tumor biomarker testing, and genetic testing for an inherited mutation, barriers in access to testing among patients from racial and ethnic minority groups, and the critical role that healthcare providers play in helping patients understand and access testing, consider its psychological implications, and make decisions about care. We're grateful to Dr. Grana and Evelyn for sharing their time and expertise with us today, and you'll learn more about them shortly. We'd like to extend a special thanks to our partner, MD Anderson Cancer Center at Cooper, for their partnership in bringing you today's program. We also thank our sponsors, AstraZeneca, Exact Sciences, and Genentech, for their support. We'd like to draw your attention to several LBBC resources that we hope will be helpful to you. These include articles about genomic testing and genetics, and information for people at high risk of developing breast cancer. We also have blogs about people's lived experiences with genetic testing, and a support community on Facebook for people at high risk of developing breast or ovarian cancer. You will receive links to these resources by email after the program, so you can share the information with your patients and colleagues. We will also be developing some new resources about genomic and genetic testing in the coming months, and we'll share those once available. Now, let's move on to a few final details before the presentation. Please submit your questions for the speakers through the Q&A feature located at the bottom of your screen at any time during the program. We ask that you frame your questions in a general way so they can be helpful to all participants, leaving out any patient-specific information. Dr. Grana and Evelyn will respond to as many questions as possible after the presentation. For participants who would like to use closed captioning, you can select this feature by clicking the up arrow button next to closed caption on the bottom of your screen. Then click Show Subtitles to start displaying the captions. We'll be emailing you a link to an evaluation after the program. Your feedback is very important to us in planning future healthcare provider programs, and we appreciate you taking the time to share your input. We're unable to offer CEs or contact hours for this program. However, certificates of participation are available upon request through the evaluation process. To receive our certificate, you must participate in the entire live session today online and submit your evaluation by May 31st. Certificates will be emailed to you by June 21st. We are recording the session and will post it on lbbc.org about a week after the program. We will notify you via email when the recording is available. It's now my pleasure to introduce Dr. Generosa Grana of MD Anderson Cancer Center at Cooper. Dr. Grana is the director of the Cooper Cancer Institute and head of the Division of Hematology and Medical Oncology of Cooper University Hospital in Camden, New Jersey. Dr. Grana serves as an associate professor of medicine at the Robert Wood Johnson Medical School in Hematology and Oncology at Cooper University Hospital. She is also adjunct professor at the Coriell Institute for Medical Research in Camden, New Jersey. Dr. Grana has received numerous awards, including the Johnson & Johnson Community Health Crystal Award and the American Society Silver Chalice Award. Dr. Grana is a member of LBBC's Medical Advisory Board. Dr. Grana, we're happy to have you with us today.
Thank you so much. It's a pleasure to be here.
Thank you. It's also my pleasure to introduce Evelyn Robles-Rodriguez, an oncology advanced practice nurse at MD Anderson Cancer Center at Cooper in Camden, New Jersey. Evelyn serves as the Director for Outreach, Prevention, and Survivorship and is bilingual in English and Spanish. She is committed to the cancer education of the lay and professional communities. Evelyn's research interests are in breast cancer, solid tumors, cancer screening and prevention, women's health, and cancer survivorship. She is also a member of LBBC's Medical Advisory Board. So welcome to Dr. Grana and Evelyn. You can please, you're both already on screen, wonderful. And I invite you to join to share your presentation at this time, and I'll turn things over to you. So thank you.
Thanks, Stephanie.
Let me share. Can everyone see that?
Great.
Wonderful. So Evelyn, why don't you get us started?
So thank you so much, everyone, for joining us. I was briefly looking at the chat and saw that you're from all over the United States, so that's very exciting. So our talk today, Unraveling the Strand, Navigating Genetic and Genomic Testing with your patients. Hopefully you're going to get wonderful information that will be helpful for you in your practice. In terms of disclosures, Dr. Grana has received grants from Pfizer Pharmaceuticals for breast equity research, and I have also received grants from Pfizer and Genentech for breast equity research. We want to thank so much Genentech, who gave us funds to provide the information that for the research that we're going to review today. And as Stephanie mentioned, AstraZeneca, Genentech, and Exact Sciences for supporting this educational program. In terms of the objectives, we're going to talk about the latest information on genomic testing with an emphasis on breast cancer, and talk about some of the genetic testing for inherited mutations. Look at some of the barriers that our minorities face in accessing testing. Talk about the perceptions of both these testing, understand the role of shared decision-making between patients and their providers. Talk about some of the implications of these testing on the patient. Discuss strategies for increasing patient access to testing, and finally, describe some of the best practices for communicating with patients about both genomic and genetic testing. Dr. Grana.
I'm going to take the first half of this talk and really walk us through the definitions of genomic and genetic and how this plays out in the breast cancer primarily arena. But it is something that is pertinent really to all cancers. All cancer is genetic in that it's due to an alteration in a cell that has given it a growth abnormality and uncontrolled growth, but not the majority of cancers are not hereditary. When we think about hereditary cancers, only about 10% of cancers are truly hereditary due to a genetic abnormality that is inherited from one's parents. Cancer risk for the majority of individuals, again, is partially affected by the genes we are born with, but it's also affected by endocrine environments, exposures, reproductive life, and other factors. And it often is the interaction of genetics and the environment that is the biggest cause of cancer. When today we talk about genetics, we're going to talk about germline abnormalities that we are born with and how they affect cancer risk. But we're also going to spend a fair amount of time talking about those somatic or cancer-specific abnormalities, those abnormalities that cancers acquire that affects their growth and affects their function, and now are becoming targets for our drug therapy. So again, germline mutations, every cell in the entire organism has the affected genetic abnormality. These are abnormalities that are in every cell, and by definition are in our egg and sperm, sperm if you're a man, egg if you're a woman, and they therefore have the potential to be transmitted to the next generation of individuals. Somatic mutations, on the other hand, are abnormalities that happened in a cell that has led to a cancer, and they are present only in the tissue that is being tested. They're not present in the gametes, so they're not abnormalities that are transmitted to the next generation. So again, when you think of germline mutations and germline testing, you're thinking about the patient and their offspring. When you're thinking about somatic abnormalities, you're thinking about that particular cancer and the alterations that cancer has gone through and how the information can be used to treat the cancer. When we think about, again, genetics, typically we think of genetics as the study of single genes that are inherited at birth, that are present in our germline and can, again, be transmitted. But we are also moving in the direction of, even in the area of genetics, at looking at other abnormalities, looking at multiple genes and how they interact together, so not just a single gene, but also looking at SNPs and other pieces of DNA that are inherited that may not have the same risk of cancer as a BRCA1 or BRCA2, but that will impact cancer risk. So again, in our current world today, we're going to talk about single gene conditions, but know that in the future, that probably will not be the case. We're going to talk about how these traits are passed on and how they can, testing for these genetic abnormalities can help us to determine screening strategies and treatment options for a particular patient and their family. When we think about genomics, we're looking at all of the genes or many of the genes that are present in the cancer, how they interact with each other, and we are actually looking at how those specific mutations can be targeted by drugs or specific treatments. And I'm going to give you some specific examples with regards to breast cancer and how this field is evolving. I would say that both genetics and genomics are fields that are rapidly changing. We've gone from BRCA1 and BRCA2 in 1995, now to panels of single genes that are 100 plus in length. And our understanding of genomics has really evolved from a few genetic abnormalities to now, again, large panels of 200 to 500 genes that can be tested for. So let's begin first by thinking about genomics. And we said, again, that it's an evolving field. In the past, when we thought about a cancer, we thought about the tissue that it was derived from. In the 1950s, the introduction of the TNM classification of cancers, tumor size, nodal status, and metastatic status, is something that we've all lived with, and we looked at that as the way to define a cancer and to plan treatment for a particular cancer. In addition to the TNM stage, we also then learned about the estrogen, progesterone, and HER2/neu receptor. But again, those are things that are specific to the cancer. And you use that information to plan for treatment. So a stage 3 breast cancer is treated with chemotherapy, radiation, hormonal therapy, depending on the features. But that is the world we lived in until probably the last 10 years. And now the paradigm is changing. And the era of genomics has finally led us to begin to think about maybe the fact that tissue of origin is not the only thing that we need to be thinking about, but we need to be thinking about the alterations in that tissue that have occurred over the lifespan of that cancer and how specific alterations can be used to treat. And we're also learning that some of those alterations are not tissue specific. They can be seen in lung cancer and breast cancer and colorectal cancer, and they have similar implications for each of those cancers. To give you an idea, the FDA approved the first cancer drug that was not tumor specific, but based on a genomic test result in 2017 with the approval of pembrolizumab, known to you as Keytruda. And that approval was for cancers that had microsatellite instability or microsatellite high. also for cancers that had a high mutation burden. So that was the very first drug that got approval on that basis. In November of 2018, a different genetic abnormality in a cancer, the NTRK fusion testing that can be defined, led to the approval of a drug called larotrectinib, which can be used. Each of these drugs now are not just being used on a breast cancer or a lung cancer or a colon cancer, but each of these drugs can be used on a cancer agnostic way to treat any cancer that has this specific genetic abnormality. So again, we've moved from treating based on TNM classification to treating based on the genetic change that has occurred in a cancer that can guide us. Genomics has also, in addition to changing how we begin to think about cancer, has really led to a change in how we do clinical trials in cancer. In the past, we did clinical trials based on a tumor type. You had clinical trials in breast cancer that were done in triple negative disease. You had clinical trials that were done in HER2 positive disease and clinical trials that were done in ER positive disease. But now we are moving to a world in which we have people of different types of cancers that are being put in a trial based on a genomic abnormality that targets that abnormality. And I'm going to show you how the paradigm has changed a bit. So there are two types of trial designs that are currently being used that are very interesting. The first is called an umbrella trial, and that is a trial that has one cancer. So it could be breast cancer, but it will enroll patients that have different genomic alterations, and they'll be enrolled onto different pieces of the trial based on the drug being tested. So there may be a drug that has a PI3 kinase mutation being tested for patients that have breast cancer with that mutation. A second drug may be used that has a different alteration, and a third drug will be used for a different alteration. The different trial is a basket trial, and basket trials are becoming more and more common. These are trials that enroll multiple types of cancers that have one common genetic abnormality. So again, there may be something that is a genomically specific lesion, and you then look for any cancer that has that abnormality. So it clearly has changed the field in the world of drug testing. In the past, this was a complex field. It was a slow process to do genomic profiling of a cancer. You've heard it. Some people describe it as next generation sequencing. Some people describe it as precision medicine. But the idea is that it's the sequencing of the genetic profile of a cancer, and the results that you get will then be used to decide on treatment and also to look for clinical trials. When we started this process, we had Sanger sequencing that looked at one gene at a time, very cumbersome. In 2014, we moved on to next generation sequencing, which was really much faster and gave us access to many more genes. And we are continuing to evolve in this field as the process changes. I'm putting here an example of a test. Now, the commercial test companies that are currently on the market, you've heard names such as Foundation, Caras, Garden 360. There are several companies that are on the market and others that are coming into this field. And what you get when you submit a cancer for testing is a report that looks a little bit like this. This happens to be one of our patients that had Foundation testing. And you can see that the test was done, multiple genes were tested, and this particular individual had many genetic abnormalities. He had 20 genetic abnormalities that were identified. 2 actually had specific findings that could be used to guide drug selection. 2 that actually were shown to lead to lack of a response, and I'll give you an example. We now know that if a breast cancer has an ESR1 mutation, that those cancers tend to be resistant to aromatase inhibitor therapy, so that cancer may well be treated with fulvestrant and a new drug that just came on the market called Orserdu, which is again a drug specifically now being marketed to cancers that are ESR1 mutated. And these results also give you access to clinical trials. So this particular patient had 18 clinical trial opportunities for that patient based on the genetic profile that you see in front of you. So again, very helpful in selecting drugs, very helpful in avoiding certain drugs, and very helpful in thinking about clinical trials that could be important. In this cancer, you can see that this cancer has microsatellite high status. That is one of the criteria for approval of pembrolizumab. So again, a really useful marker. So genomic testing, the pros and the cons. We're not there yet. It's not a perfect science. It allows you to identify driver mutations, mutations that have a bigger role to play in the cancer arena. And it does hopefully help you identify more effective treatments, helps you avoid ineffective treatments, and helps you potentially hone down for clinical trials on a population of patients that may benefit. Those are all the pros, but the reality is that our knowledge of genetics is still evolving, so we don't necessarily have drugs for each of these targets. We don't necessarily understand these pathways very well. There are many cancers that, despite the most sophisticated of tests, we don't find any actionable items that can guide you. Some of these tests require biopsies, others can be done on blood, so we can do liquid biopsies. And then we sometimes find a lot of passenger mutations that may really have no identifiable purpose or no identifiable target. So again, I think it's a moving target, but it is an exciting one. Now, looking back at this concept of targeted therapy, it is basically the idea that you've identified a specific abnormality, a specific protein that you can then target with a specific drug. This is data from the European Journal of Cancer, and in this particular trial, it was shown to be a very useful process. There were 1,100 patients, over 40 cancer types, and they, in this trial, looked to see if matching treatment based on the genomic abnormality was better than just randomly assigning treatment. The study was one of the first to show that you can actually improve median survival when you do matched treatment, drug selected against a genomic abnormality that you've identified versus random treatment with any drug of your choice. So again, not all studies have shown the same thing, so I think this is still a moving target, but this is the hope. The hope is that by selecting a target and selecting a drug that's specifically honed to that target, we will do better. The current drug that just got FDA approval, Orserdu, is an oral SERD like fulvestrant, and that drug was shown to be particularly effective in women that had an ESR1 mutation in breast cancer with metastatic disease. So again, the concept that if you can have a focused target, you can do better. So with that, I'll leave genomics, but let's talk about genetics and the concept of genetic testing and where we are moving in the world of genetics. So the difference between tumor and germline testing is very significant. And sometimes you need both, because you can do a tumor test and you may find an abnormality in your tumor test that suggests that there may be a hereditary abnormality in that individual. So you then have to follow through with germline testing. And so again, I think we are learning that oftentimes these two are complementary. We sometimes do germline testing to follow up on these mutations found in the tumor. And if you confirm that that individual has a germline mutation, you can then give that individual specific information and you can guide the family. So again, I want you to begin to think of these as complementary, and oftentimes one can affect the need for the other. When we think about hereditary cancer syndromes, we think of germline genetic mutations that are associated with an increased risk of cancer or a syndrome of cancers in a person or a family. And I'm going to show you some examples of these genetic syndromes. Mutations are passed from a parent to a child. This is a family tree that shows the mother having, or the father, but clearly an individual transmitting the affected abnormality to their offspring. In this case, the mother in blue has the genetic abnormality. 50% of her children will be at risk for inheriting the abnormality. So 50% of each child has a 50% chance, and on with each generation. So a mutation like this, 50% chance of transmitting it to the next generation, regardless of gender. In these mutations, there's no gender specificity in BRCA1 and 2. And depending on the specific gene, there can be a variable risk of cancer. I'm going to show you some high risk genes and some that are not so high. And then there can be significant differences in families that are not completely explained as of yet. Some families carrying a specific abnormality have lots and lots of cancer, while other families may have lower amounts. And that's where environmental factors may be playing a role, or other genes that those individuals carry may be affecting that risk. Up until 2013, so I told you 1995 was the beginning of genetic testing in the breast cancer field. BRCA1 and BRCA2 were identified in 1995. And between 95 and 2013, research was limited because Myriad Genetics held the patent on these two genes. And if you wanted to do testing, you had to go through Myriad Genetics. So all we really knew about was BRCA1 and 2. We knew about a couple of other genes, P53, because it's a very rare syndrome, Li-Fraumeni syndrome, that has brain tumors, leukemias, and sarcomas. But by and large, it was a BRCA1 and 2 world. But in 2013, as the patent went away, many companies started coming forward with what are known as multi-gene panels, where rather than just testing for BRCA1 and 2, you can test for anywhere up to 100 genes in that particular blood test. And what you can see on this slide is that about 50, if you look at an individual that you're doing testing for breast or breast and ovarian cancer, about 50% of the time you find mutations in BRCA1 and 2 as the cause. But again, in about the other half of the cases, you find other genes. The most common of those other genes are PALB2, CHEK2, ATM. Those are relatively common. And then a smaller group of genes, that Li-Fraumeni TP53 gene that I told you about, some of the Lynch genes, etc. Now, how often do we find a genetic abnormality in an individual? The likelihood of finding an abnormality depends a little bit on what you're starting with in terms of risk. So if you're starting with a Jewish woman who has breast cancer in her 30s, the likelihood is high. If you're starting with a woman who had breast cancer in the 60s and no family history, the likelihood is quite small. So your yield from genetic testing is very much affected by the family history and even the ethnicity of the individual. Now, again, as I told you, BRCA1 and 2 were what we started with, and this is then has increased dramatically. We now can begin to bundle genes into high-risk genes where the risk of developing breast cancer is 40 to 60% over an individual's life. BRCA1, BRCA2, CDH1 has gastric cancer and lobular cancer as part of the syndrome, PALB2, P10 Cowden syndrome, and again, Li-Fraumeni. And then we have these moderate risk genes, ATM and CHEK2 being, and the neurofibromatosis gene being the typical ones where the risk is not quite as high. It may be 20 to 40%. But these are actually genes where the importance of family history is really critical in determining what the risk may actually be, because you may have families that have a very high risk and others not so much. And then we have a group of genes that may have an increased risk of breast cancer. The data is not quite there. The Lynch syndrome of genes, MSH6, MSH2, PMS2. Again, how much those increased breast cancer risk is being evaluated. And the list on this potential increased risk changes. Some genes come on, some genes drop off. The future is actually evolving. The future in the genetic testing world is moving from just testing for 100 genes to potentially doing whole exome sequencing, where you analyze every region of the human genome that codes for a specific protein. And so I think our future is going to be very different. But as you analyze for more and more genes, you also have the opportunity to find what are known as variants of uncertain significance, or genetic changes where really the true significance is not clear. And now we are actually developing tests to try to study those variants further. A variant of uncertain significance is an alteration in a gene where there is not yet concrete information about its true significance. The classification may vary from one lab to the next. And we often don't recommend that family members be tested for variants of uncertain significance because we don't know what they mean. Some of these variants will in the future be reclassified. Some get reclassified as, yep, this is pathogenic, this is harmful, or no, this is really a random finding in the population. So these variants of uncertain significance are important, and Evelyn will tell you more about how we find these in minority populations, but they really are our current stumbling block. So what does a negative genetic test really tell you? It tells you that you haven't yet identified an abnormality, but it doesn't really completely clear the picture. Individuals in that family may still be at increased risk based on personal risk factors or their family history. All you can say is that there's no concrete gene that I can test family members for right now. You make screening and risk reduction recommendations based on the family history rather than a test. And you often have to have a lot of information for these families to make sure they understand that just because we didn't find a genetic abnormality, it doesn't mean that they are free of risk or not. Now, this is for families where no genetic abnormality is found. On the other hand, when you have a genetic abnormality and you test family members and they're negative, that's a wonderful thing. A positive test result can tell you that an individual has an increased risk due to that genetic abnormality, and the risk may vary based on the genetic abnormality. You can use that information to make treatment decisions. Some women choose bilateral mastectomies if they have a BRCA1 or 2 mutation. We actually now are in a world where drugs like Lynparza, which are used to treat breast cancer, are selected if there's a BRCA1 or 2 mutation. And some trials now are being done based on a genetic abnormality. You can use the information to make cancer screening and risk reduction decisions. Again, how do you screen a woman who carries a mutation? The role of MRI to screen those women, the role of prophylactic mastectomy, prophylactic removal of the ovaries, the use of drugs to lower risk, and even lifestyle changes that could lower an individual's risk. But the key about a positive test is that it's not just for the individual in question, but it really affects the entire family. Because if an individual is positive, each of their siblings has a 50% chance of being positive, and each of their children has a 50% chance of being positive. So you can use the information to weed out who needs screening and who doesn't, and you can use that information to guide the family. Again, if an individual tests positive for a mutation, we then reach out to the rest of the family because decisions need to be made about increased surveillance, MRI, ovarian screening, prevention, prophylactic surgery, and lifestyle change. So I would argue that this information is incredibly powerful for the patient being tested and also incredibly powerful for the rest of the family. So with that, I'm going to stop, and Evelyn is going to move us on to barriers to care and the role of this information in our diverse populations. Evelyn.
Thank you, Dr. Grana, for that excellent overview. So I'm going to go on and talk a little bit about disparities, and I'm just going to move my camera over. Disparities in testing, and then talk a little bit about our study and the information that we found. So first, we know that genetic testing is underutilized in our Black and our women of color, and that is due to a variety of barriers when trying to receive that genetic counseling, the testing, and that has been based on a lot of information in the literature over the years. We know that there's also a lack of sufficient diversity in genetic testing participation, and that this further perpetuates the difficulties for, again, Black people and women of color and people of color who do want to undergo hereditary cancer genetic testing. So in terms of reported barriers to counseling for our minority populations, first may be the fact that there may be a lack of referrals for these people to get tested. When we look at the literature, we see that there is a less likelihood for Black women to be referred for genetic counseling and testing when compared to Caucasian women. We also know that the cost may be prohibitive, not as prohibitive in the past when the test was, $3,000 to $4,000. Now you can get multi-gene panels for $250, and a lot of insurances cover it based on meeting the criteria. So that has been very helpful in helping decrease that cost as a barrier to care. And then there's also that self-motivation. If people really don't understand or haven't had the education around the importance of the testing, then they are less likely to want to proceed with getting counseling or testing. And some people are also unaware that genetic testing is available for more than just looking at your ancestry and where does your family tree originate from. Other barriers include the emotional impact of the results. From having done this in the past, we can tell you that there can be feelings of feeling guilty because you have this mutation that has now been passed on to some of your family members, and people can feel upset, upset that also they may be tested positive and a sister or brother negative or vice versa. And we know that these results are something that can impact the entire family. We have had families where one person wants to know the results and the other person doesn't. But, some of the things that sometimes can cause one member to proceed with, as an example, prophylactic mastectomies can kind of guide or tell people what the results were, whether they wanted to know it or not. There's also worry about discrimination, especially about life insurance. We have had patients that have not chosen to get tested because they're concerned about how that might affect their insurance. And some people are just uninformed about some of the federal and state laws that are used to protect both employment and health insurance coverage for patients who undergo testing and are positive. And then there can also be, the issues with mistrust of the physicians in the medical system. We know that some of our minority patients have had poor experiences where they feel discriminated when they go to providers, and that has made them a little bit more cautious with undergoing certain tests or even showing up for getting counseling. And nationally, there have been events, as we all know, in research that have impacted even further the distrust of our minorities in being involved with current healthcare, with being involved with proceeding with certain tests, and with getting care at certain healthcare systems. This is just showing you that there are variants of uncertain significance, and that they, as you can see, are more impactful, more common in certain ethnicities. When you look specifically at the genes for breast or colorectal cancer, and you look at the number of genes that can be impacted based on ethnicity, you can see that based on what your ethnicity is, if, as an example, when you look at the number of genes being in the lower end, in the 3 to 9 genes, having variants, it's more common in people of Asian descent. But when you look at a more number of variants at 20 to 46 genes, then you can see that African Americans tend to have a little bit more compared to your Caucasian counterparts. In terms of BRCA1 and 2, we know that they're estimated in the general population to be found in about 1 to 400 to 800 within the general population, and that the likelihood of having a pathogenic mutation really increases when you see more than one female in that family with breast cancer, and even more when you start seeing not just breast, but also ovarian cancer. And the estimated risk to carry one of these mutations can really vary by ethnicity. So again, as Dr. Grana had mentioned, if you are someone of Ashkenazi Jewish descent, your risk of that BRCA1 and 2 gene are higher, especially the BRCA1, higher if you're of Ashkenazi Jewish descent, compared to the BRCA2, where we're starting to see them a little bit more in women of African American descent. In terms of triple negative breast cancer, these are breast cancers that are negative for some of the hormonal markers, such as estrogen and progesterone, as well as HER2/neu, which is a protein that can be overmade in some breast cancers. But it is a cancer that is more common in women of color. It's diagnosed in women less than 60 years old more often, with or without a family history, if you meet the criteria for NCCN. And there has been found in a West African founder mutation in the BRCA1 gene, in a particular part of the gene. There was a study that was done by Ramel et al. In 2013, where they found that there was a higher percent of BRCA1 mutations in women with triple negative breast cancer when you compare it to white women with triple negative breast cancer. We also know that, unfortunately, not just for genetic counselors, but for providers in general, that unfortunately the providers that are providing counseling and care for individuals that are getting genetic counseling and testing really do not mirror the diversity of individuals that we serve. There was a survey that was done in 2020 by the National Society of Genetic Counselors that found that approximately 90% of counselors self-identified as white or Caucasian, and only approximately 2% of African American descent. And in the 20 edition, you can see that there was not much different. In 2008, 92% reported being white or Caucasian and 1% as African American. So we really want to try to encourage our minorities to become involved and to get educated, to become genetic counselors. Is an awesome profession. You need a master's degree, and the more that we encourage our minorities to become in these healthcare fields, the better we can provide service to the different ethnicities that we care for. So I want to talk a little bit now about our grant that we received from Genentech, specifically looking at women of color and what they understood about genetics and genomics. So this was our poster that we put together based on feedback from our minority advisory group and professionals in our field, where we basically were telling them that, you know, breast cancer has a lot of layers. We want to talk to Black and Latinas about their understanding of cancer testing, how you make decisions. And also we did have a small payment that we gave people who participated in the study to thank them for their time. But it was basically a 90-minute small group discussion focus group focused on women of all stages of breast cancer who were either of Black or Latina descent and over the age of 18. So these women were all treated at MD Anderson Cooper. We had a total of 29 women participating in 8 focus groups, and 60 had been scheduled, but some of them had to be rescheduled several times, which unfortunately can happen not just with our women with metastatic breast cancer, but with our minorities who are dealing with a lot of other issues. 8 of the women were Latina and 21 were Black, and their ages went anywhere from 39 to 79 years of age. There were several key questions that we focused on. One was trying to find out what these women understood about their treatment, who had completed their treatment, or were living with metastatic breast cancer, understood about genetics versus genomics, how these women described their barriers to access to care, the role of themselves and their healthcare providers in making decisions, and finally, their preferred ways to learn about receiving complex health information. So what did we find out from this study? What were the patient perceptions? First of all, that in terms of genetics, they did understand a bit more what genetic testing was, due to the fact that many of them had participated in getting testing and counseling. And there was a lot of varied perceptions about what inconclusive results meant to them. For some of them, they thought that it meant that there was no value. And for some of them, they thought it meant that there was nothing was understood about what was going on with their testing, or the fact that they really didn't have the information that they needed to date to move forward with decisions. The most frequent reason why these women decided to get testing was due to family. Either they wanted to find out information about their past family, they wanted to get information that would impact their cancer and its care, or they were trying to find out if this testing result would impact their future family. So in terms of what they understood about genomics, it really was not a well-recognized word. However, when we described to them exactly what genetics was, several of the patients did recognize that when they heard about this, there was also a talk about targeted therapies, and especially for the specific type of cancer that they had. So sometimes it was not so much that they didn't understand the concept as it was that they didn't understand the word itself or did not remember hearing the word genomics itself. In terms of understanding barriers to care, one of the big barriers, which is very common in our minority communities, is the cost of care. Even when they had insurance, sometimes there were gaps in coverage, which prevented them from getting the care that they wanted to at the time that they wanted to. In terms of learning about their cancer, they felt that sometimes they received information that was shared too late, maybe after the treatment was ended, or they felt that they didn't receive that information when they were receiving their care. As an example, did they hear about all the treatment options? Did they really understand what the severity of the side effects of their treatment were going to be? And would they have made different decisions had they had that full information? They also felt that there was a pressure to act quickly. Either internally, they felt that they had to act quickly because they wanted to move forward with getting their cancer treatment as soon as possible, or externally from the healthcare provider and the system. Maybe they felt that they were getting pushed to make a decision as soon as possible to start their treatment. And they felt that that push internally or externally prevented them from weighing their options as well as they would have liked. There was also a feeling that their provider were not getting them follow-up as closely when the treatment was over, which is what a lot of the patients feel, that acute phase after the end of treatment, almost feeling like there's been abandonment by the healthcare providers who previously had a lot closer contact with them. And then because the study did take place during COVID-19, there was that COVID-19 isolation, which meant that a lot of them had to attend their appointments alone, unable to really get their families involved in some of the decisions, and unable to access some of the resources that would have been more available to them had COVID-19 not been in its full effect. What about the role of the provider? There were 4 roles that were identified in the focus groups. One was that the provider was a director of care, and this was seen in either a positive or a negative manner. One, in terms of positive, that they were helping guide them and giving them the information to help them move forward with a decision. And in the negative side, they were being pushed to make a decision that perhaps was not what they wanted, but they felt that they had to take because of the role of this provider. Some of them saw their providers as expert advisors, people who were providing them with all of the information and all of the education so that they can really choose the best course of action in terms of their cancer treatment. Some of them felt that they were really great sources of emotional support. Some of their doctors gave them hugs when they saw them in the office. They provided them with a phone number to reach them whenever they needed to. There were photos that would be taken at different times of their journey, and they felt that there was a strong bond that was formed with these providers. And then finally, the final role of the providers that they saw was a source of information on options. Again, this very great resource where they could get that clear, comprehensive information that would allow them to choose a good care. But this was more often associated when making decisions about surgical versus medical options. In terms about how they like to learn, there was either that information that they felt should be given just in time, meaning sorry about that. They were interested in getting information, not just when they began their journey, but getting information at multiple times throughout their journey, and in ways that they can access it whenever they were ready to get it. So effective resources they felt should be provided pre-treatment, during, and also post their active treatment. They like the concept of getting videos for education, as well as reading materials, and the opportunity to see the impact of the treatment on others to prepare for what to expect. So getting information from peers and seeing peers who had gone through that same issue. In terms of online resources, they saw it as both positive and negative. Sometimes it became a source of worry when they were getting too much information or didn't understand the information that they were getting. But there was also sites where they were getting positive information that helped them make choices about next steps. And in some cases really led to better understanding of what questions to ask their providers. And again, a source of stressors for others. And then a lot of the patients noted that they had received personalized treatment books with general information as well as patient-specific information. And they felt that these notebooks were very helpful, especially when it gave them opportunity for space to write notes. For psychosocial implications of care, they felt that psychologists and social workers were really a highly valued resource for them, but that often not something that they could readily access, that they would have loved to have a little bit more access to these mental health resources whenever they needed it. Peer supports were something that they felt would be very valuable, and not just from other peers in terms of the cancer center giving them someone, but also family and friends who had been through that in the past, who maybe they didn't know had been through that same experience, but when they told them about their cancer, their newly diagnosed cancer, these family and friends then came to the forefront and discussed it. Faith was very important for these patients, both from a religious institution as well as that personal faith or that spirituality, whether it was institutional or just something within that kept them going through the hard times. And then in terms of children and partners, it was a complex relationship. They either saw them as a source of support or a stressor, worrying about how to protect them from their diagnosis, their treatment, how to protect them from the things that were going on to them that were negative. So how can we improve access and support for genetic and genomic testing? What strategies can we put in place? First of all, in terms of educating our patients about the importance of testing, we really want to promote awareness and educate them about the value of these tests to them personally, for their families, for their treatment, and try to utilize terms that are easy for them to understand. Again, if we talk about genomics, really making them understand what genomics is. Using a combination of educational tools, both visual, reading, and if we're going to guide them to internet sites, making sure that they're reliable. And then ensuring that when we're providing education, that is provided throughout their cancer journey, in the beginning and the end and throughout, so that they have those resources and understand things throughout that journey period of their care. Making sure that we utilize laboratory resources, understanding about some of these genetic and genomics testing, the fact that for the uninsured or the underinsured, that there are patient in need resources that are available to them, and to not just give up if the patient cannot or their insurance cannot cover the test. And then ensuring that when we do provide care for these patients, that is done in a culturally and linguistically competent way, understanding the barriers that these patients are facing that are different from the Caucasian community, and making sure that we understand and have resources available to provide to them. And finally, of course, using the language that is most comfortable for our patients, even if we have to use outside resources. In terms of shared decision-making, we need to be open to the questions that our patients have throughout the treatment process. Encourage our support patients to attend the appointments so that they have that second year to understand and to ask questions. And then really understanding what our roles are as directors of care, expert advisors, emotional support, and source of information, and understanding that, these roles are very important to our patients. We may need to play more than one role, and we may need to play different roles at different part of their journey. But really important to understand and to discuss with the patients how they like to communicate, and how they like to come to decisions when it comes to their care and treatment. In terms of final words, we understand, based on all the excellent information Dr. Grana gave us, that genetics and genomics are very complex but exciting opportunities to improve the care and the lives of our patients, that there is tremendous growth in the fields of genetics and genomics, and we need to continue to educate ourselves in order to keep up with the innovations, but this can be very challenging. There's tons of information out there. That women of color do have different challenges that affect how they make decisions and how they like to communicate. And we need to utilize varied tools in order to reach them how they best like to be reached, and provide these tools throughout their cancer journey. And then seeking resources and support to educate and encourage testing can really help improve equity in this field for women of color. Let's not just stop when women say no, but making sure that they understand about what that decision is and how we're going to be able to support them throughout the process. So thank you for putting up with me as I lose my thoughts, and I'm going to now move on to the question and answer part. I'm going to stop sharing my screen and let Stephanie take over.
Okay, well, thank you so much, Dr. Grana and Evelyn, for this really valuable information you have shared with all of us. I have learned a lot, and I know that the same is true for our audience, given the vast developments in the field and all of the access and barrier-related research that you shared, Evelyn, so thank you. We've had a good number of very thoughtful questions come in from our audience. So we've got about 15 minutes, just under that, for questions. So I am going to start with the ones that have already come in. And just a reminder for our audience, if you have questions, please enter them in the Q&A in Zoom rather than the chat, so that we can see them on this end. And we'll do as many as we can in this period of time. All right, so, and I would, of course, be really comfortable with either or both of you offering comments on these. So feel free to both jump in if you would like. So one person asked, we find many men diagnosed with a positive result for BRCA2 often choose a prophylactic mastectomy. Are you suggesting this given new findings?
I'm surprised that you're saying that because the risk of male breast cancer is increased, but it's still small. We are recommending mammography to men that are BRCA2 positive, but I'm not aware of anyone in this area doing or recommending prophylactic mastectomies as opposed to women, where in the United States, a number of women, somewhere around 30+% of women who test positive for a BRCA1 or 2 will have prophylactic mastectomies. The number in other countries is much lower. In Israel, Eastern Europe, somewhere around 5% of women choose that. But the story about men is interesting to me.
Okay,
I would
thanks.
not recommend it. I think the risk is too small to consider prophylactic mastectomies in a man.
Okay, thank you, Dr. Grana. Evelyn, is there anything that you would want to add to that?
No, I think that's perfect.
Okay, great, thank you. Okay, we did have a question from somebody going back, it came in kind of an earlier point in the presentation, just to ask for a quick clarification of what the TNM system is.
TNM is tumor node metastasis. It's a classification system for cancer, and each cancer has its own classification based on that TNM. How big is the size of the tumor? That's the T. The nodal status, so node positive, node negative. In breast cancer, it's actually how many nodes affects your N. And then metastasis, yes or no, affects your M. And that's how we thought of cancer, and we still use that in our staging classification. So all staging is based on that TNM, but we've now moved beyond that.
Great, thank you so much for clarifying that. Let's see, we have a question. Is a repeat genetic test recommended for a patient with a personal and close familiar history of breast cancer if their original test was negative for all mutations 8 to 10 years ago?
So we see a number of these patients because remember that 8 to 10 years ago, you were doing before 2013. So if the test was done before 2013, it was all usually only BRCA1 and 2. And so we are often going back to those patients who had a strong family history or patients who were diagnosed young, even if they didn't have a family history. And we are recommending multi-gene panel testing now. The thing that's changed is the cost of the testing. In the past, a good test was $5,000. Now a large multi-gene panel test is $200. So even if insurance balks, it is not unusual for someone to opt to do it. Now the criteria for testing has also become much easier. It used to be very rigid, but it's expanded. So now if you're a woman with metastatic breast cancer, whether you have a family history or not, that's a criteria for testing. And many other, triple negative up to age 60 with no family history. So the criteria has really expanded.
Great, thank you so much for that additional perspective. We have a lot of questions coming as we're going, so bear with me just a moment as I scan down to see what has just come in. We've had a couple questions just about the vast amount of information for even clinicians to manage. And I wonder, maybe we could start with Evelyn on this. Just how do you, keep up to date on the, the developments, and then maybe followed by you, Dr. Grana. I think just some people who would be trying to learn from your experience here.
I mean, it really is just continued reading of the journals and the studies that come out and keeping up with them. I think Dr. Grana is extremely excellent at that. Just managing, all that information that comes in because it can affect the patient care, both for genetics and genomics. I think it's just a daily it's daily constant information that is coming in. And if you're not up to date with that, you're not going to be able to provide your patients with the most up-to-date care. So I think Dr. Grana can more talk on that.
I think it's also surrounding yourself with the people that have that information. So we are very fortunate, Evelyn and I, that we work with 5 amazing genetic counselors, and I'll be seeing a patient and I go to them and I say, hey, how have the guidelines changed? Because the guidelines change yearly. So if I didn't have a genetic counselor that could give me the answer, I would then have to go to NCCN. NCCN is by far, I think, the best, most up-to-date data that we have. You go on NCCN, they have a section on breast cancer treatment, and they have a section on hereditary cancers. And you go in, you sign in, you can sign in as a provider, you can sign in as a patient, and it really gives you constant updates. But it is difficult, and I worry for primary care physicians and how they stay on top of this, because they're the ones that really manage the woman who has a family history but herself has not had cancer, and they're the ones that have to make recommendations for genetic testing, screening. I worry about the general oncologist who sees all diseases. I am very lucky, I see breast cancer, but the general oncologist has to manage all diseases. She has to manage not just the germline genetic testing changes, but they now have to be aware of all the NGS implications. And so it is very challenging.
Yeah,
there was
absolutely.
one question that I saw coming through the Q&A that I wanted to make sure we touched on, and that was the question of when should you do germline testing versus NGS? First of all, in today's world, NGS genomic testing is for the patient with metastatic disease. We are not using NGS for early stage cancer. It's starting to move in lung cancer where they're doing some of that testing earlier. It's starting to move in melanoma where they're doing a little bit more, but in breast, it's really only for the metastatic patient. So oftentimes you'll have an opportunity to do genetic testing on a woman in her early diagnosis. But if the woman presents with metastatic disease, you should do both. You should do germline and NGS, and insurance typically covers both for metastatic disease.
Great. Thank you so much for addressing that question. It is a really important one. Evelyn, we have a specific question for you about access to genetic testing for Hispanic and Latinos. Is this being studied?
So it's definitely being studied. I think it's just that the number of Hispanic and Latinos that have been tested haven't given us as quite the number of information we need to move forward with what mutations are more common in them. As we continue to really get our Latinos involved in genetic testing and genomic testing, I think that that information, like those mutations that are more common in the African-American community, will start coming out as well.
Great. Thank you. Was there anything, Dr. Grana, you would want to add to that? Okay, thank you. Somebody asked whether a high oncotype has any link to genetics.
Good question. So oncotype is actually one of the first genomic tests that came about, because basically, so when I said NGS is for metastatic disease, yes, that's right. But oncotype is a mini NGS for early stage breast cancer, because oncotype is taking the cancer, the tumor, and testing it for 22 genes that are expressed differentially in that tumor, and using that to generate a score that can then be used to decide on whether chemotherapy is needed or not. MammaPrint is another sort of mini NGS for early stage breast cancer. It looks at 70 genes and how they're expressed in the cancer and how that can guide you in terms of treatment of the cancer. But no, the NGS, the oncotype score doesn't help you to predict genetic abnormality or not. It is completely independent. We do know that BRCA1 tends to be triple negative, so we don't go the oncotype route. BRCA2 is more often ER positive, so some of those patients will get oncotype testing done, but they are different. The genomics of oncotype are different than the genetics, and they don't cross paths.
Great. Thank you for, again, some additional clarification. And
because it is, it's really NGS for early stage disease, if you will.
Great. Thank you. So here's another question that just came, I think, as you were answering that, that also relates to oncotype testing. Do you feel there is a difference in oncotype testing outcome, whether it's from a biopsy instead of a surgical specimen?
So there's been a lot of debate about that. In the era of COVID, we were using Oncotype on the biopsy because we needed to make decisions about treatment and we didn't necessarily have access to rapid OR time. I would say that most people prefer to use Oncotype on the final pathology because you basically look for your most aggressive area of tumor and you send that for your Oncotype testing. Whereas and you have much more tissue to play with. If you're doing it on the surgical specimen, those specimens are smaller. You may or may not have enough material and it may not be as representative. So I would say by and large, if you have a choice, people will use the final. Some people are using Oncotype prior to surgery to plan whether a patient may have chemotherapy or endocrine therapy alone. And in those cases, you have to use your biopsy.
Okay, excellent. Thank you so much for that information. So somehow this time has flown and we just have time for one more question. Maybe I'll invite you both to share your thoughts. It's hard to pick because we've had a real good number come in from the audience. So we had somebody ask, is there a known reason why there appears to be an increase in breast cancer among young women in their early 30s? So I'm going to add on, is there any connection there between what we're seeing and genomic and or genetic testing?
There is, first of all, I could say that we don't know why we're seeing an increase, whether that is, there's been some speculation that women are starting periods earlier, women are delaying childbearing, and that all contributes to risk in some way. But that is probably not the whole answer. We don't know the whole answer. It is not all genetic. So although the younger a woman is, the more likely that she carries a genetic abnormality, there are still an awful lot of young women diagnosed. We have several in our practice in their 20s with no genetic abnormality, in their 30s with no genetic abnormality. So the rate is higher that you'll find the genetic abnormality, but many don't. And so by and large, I think it's still an unsolved question.
Okay, thanks for your thoughts there. And Evelyn, anything you would add to that kind of concept or question?
Nope, no, thank you.
Okay, well, great. Thank you so much. So at this point, that is all the time we have for questions. I literally cannot believe how quickly it went. And I want to thank you both so very much and for our audience for being a part of this and keeping it very dynamic. And on behalf of Living Beyond Breast Cancer, I do want to thank you, Dr. Grana and Evelyn, for sharing your expertise and your valuable insights with us today. There have been so many major shifts in testing, its impact on treatment, and then the access barriers and equity in care. So a lot to cover, and you did an amazing job with it in the amount of time that we have had. I'd also like to, again, thank MD Anderson Cancer Center at Cooper for their partnership, and then AstraZeneca, Exact Sciences, and Genentech for their support of this program. So as a reminder to our audience, you will receive an evaluation link today. Please remember to complete it for us no later than May 31st. We are also going to place the link in the chat for anybody who'd like to do it now before we wrap up. For those of you who do request a certificate of participation, a reminder that that will be emailed to you by June 21st. And we're also going to send a link to the program recording and the slides within about a week from now. So thank you, everybody, for joining us today and for the care that you provide to people affected by breast cancer. We hope you'll participate in future LBBC programs and take good care. Enjoy the rest of your day. Thanks again.
Thanks, everyone.
It's really wonderful. And thank you for having us.
Thank you so much.